Welcome everyone to today's webinar, How to Unlock Capacity and Drive Down Length of Stay, Real-World Insights from Health Fairview's Digital Transformation. I'm Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Ahmad Rashid is on the customer success team at Quantus, where he works with Quantus's network of health system partners managing the deployment and adoption of the Quantus solution. Prior to his role at Quantus, Ahmad spent the last decade in the healthcare IT industry as an operations leader. He has held numerous leadership roles at healthcare IT companies, focusing on everything from reducing hospital-acquired infections to increasing ambulatory care access to patient engagement. He earned his bachelor's degree in economics from the University of Georgia. Julie Stepney is Vice President and Chief Nursing Officer at Health Fairview, Bridges Hospital. She also holds the title of Executive Sponsor for their Systems Operations Center. Julie has held numerous leadership roles over her career, working at Kaiser Permanente in Kansas City, TriHealth in Cincinnati, and for the past 9 years at Health Fairview in Minneapolis. She received her nursing diploma from Nebraska Methodist Nursing School, her Bachelor of Science in Nursing from Webster University, and her Master of Science in Nursing from Xavier University in Cincinnati, Ohio. At this time, I am pleased to turn the floor over to Ahmad to begin today's presentation.
Thank you, Ayla, and thank you everybody for joining us today. I'm going to start off by introducing Quantus, and for those of you who aren't familiar with us, we're essentially the patient automation tool or patient flow automation tool for healthcare. We've got a comprehensive set of offerings that kind of bucket into three basic elements. First, we've got an AI and behavioral science-based technology platform that brings new innovations to the world of hospital operations. Second, we've got a predefined set of software and best practice processes that address key operational issues. And third, we've got an expert professional services team which provides on-the-ground support for solution design and change management. We're a proven partner with over 70 health systems and hospitals around the country, and we've driven some pretty transformational results. Everything from reducing inpatient length of stay to reducing ED length of stay and left without being seen rates, all the way to lowering PACU exit delays. And typically this ends up amounting to about tens of millions of dollars in benefit for our customers. Today, we're going to go over, this is the agenda for today, and we're going to start with a brief introduction to patient flow automation, including what it means, how it works, and what it can do for your organization. And then we'll spend the majority of the time hearing from Julie on the digital transformation at Health Fairview, how it started, where they are now, how they're achieving sustainable results, and then we'll leave about 10 to 15 minutes at the end for Q&A. So first, starting with patient flow automation. So why are we all here today? As we all know, there's a lot going on in healthcare at the moment. We're facing ongoing margin pressures, staff is burning out, there's increasing interest in more affordable healthcare and in patient experience. Now, there's a lot more going on, but those are some of the big buckets. And what we hear when we talk to leaders across the country is that, amidst these challenges, there's a strong interest in going back to fundamentals and going back to basics. And what that means is essentially improving operations can really be what we call a silver bullet for simultaneously decreasing costs, increasing revenue, addressing burnout, and enhancing the patient experience. And what you're seeing here is essentially a survey done by Foresight Health of over 60 health executives last year. And what they heard was that improving operations and efficiencies was the #1 strategic priority. And if you kind of dig a little bit deeper around into that, in operational efficiency, one of the key components that everybody was focused on was length of stay reduction. So it's really no surprise that you guys are all here, and we can't underscore the importance of the content we'll be going over today. So length of stay. There hasn't been much change in the last couple of decades. We have gotten more digitized as a world. Over the past 10 years, we've even gotten more digitized as a healthcare industry, but length of stay has remained largely flat. And within that length of stay, about 25% of it is excess days or avoidable days as calculated by the advisory board. Now, some of that excess day are things like, really hard issues like post-acute bed placement and getting patients out to, where they need to go. But a lot of it is actually pretty attainable stuff like, hey, we're not putting in orders on time, and so we're actually struggling to get patients out because they've got orders to complete, or we aren't putting targets against length of stay, so we're keeping patients longer than we need to, et cetera. So even though there are a lot of hard issues, a lot of the change that can be made is actually pretty easy and achievable. And I say easy with a big asterisk there. There's always a journey, right? So even though that there is a lot of opportunity, a lot of things we've tried in the past haven't really bent the curve. So it's clear something has to change in order to gain a step function improvement. And this is where Quantus comes in. So at a very, very high level, we're a complement to your existing infrastructure, and we integrate with your existing EMR and other systems. And we bring in new innovation and automation technology that's really worked in other industries to healthcare. So we kind of start here at the bottom, where we're taking data in from your existing systems, and generally it's about 5 to 7 years of historical data as well as real-time data. And we're layering on our predictive intelligence, our AI and machine learning algorithms. And those actually uncover, hey, what are trends in patient throughput that we're seeing, and then what are bottlenecks, most importantly, what are bottlenecks that are going to occur. Additionally, we layer in our data science to identify, okay, we know these bottlenecks are going to occur. What are some of the things that affect these bottlenecks that we know we can change, or at least work to change? And then we use our behavioral science to actually set up processes to manage that change and address these issues and sustain some of the change management over time. And so we've done this a lot, and we've had a lot of reps under our belt, and that's where we kind of get into our patient flow solutions. These are prepackaged solutions that we use that are tried and true and we know work, that we actually bring to your organization. And we do these design efforts. We understand, what the unique issues at your hospital might be, and say, all right, this is of our pack of solutions, what might work for this hospital. And on top of that, we layer in our expert services, right? Going through change management, setting up new processes, setting up the management layer, setting up the accountability is not easy. And what's worked everywhere else, how is everybody else doing it? And how can we get there, or how can we help you get there? That's where our expert services come in. They drive the process behind designing, governance, change management, sustainability, all of that good stuff. So getting in a layer further here, we've got our approach, right? So what we like to do is implement what we call a closed loop management system. And it has 3 main components. That's identifying issues, orchestrating actions, and managing accountability. So identifying issues is pretty self-explanatory, and traditionally this has been historical, right? So you look at it on a quarterly basis, you look at your reports, or monthly or weekly or daily basis, but it's always looking sometime in the past and hoping that we can glean something to change in the future. What we'll do is actually provide you that data real time, and of course proactively, to help identify the issues as they're occurring and before they occur. The second step is orchestrating actions. You can't just identify issues enough. We've already had kind of death by a dashboard in healthcare. So what are the key elements that we can orchestrate or automate to actually unlock patient flow? And so at the moment, or in the status quo, you might be orchestrating discharge planning by phone calls or text messages or emails. I've even seen fax used still from here and there. So how can we actually get folks away from doing that level of coordination and automating some of this coordination for discharge planning. And the third step, which is arguably one of the more important ones, or maybe the most important one, is managing the accountability. To really drive change, you need to close the loop and hold teams accountable while managing the accountability. You need to understand whether you're identifying the right issues, what teams are actually taking the right actions, which teams might not be or need some coaching. And you need a system that can do this automatically over time, which requires some really sophisticated data science and statistical outcomes analyses. And what we found after years of working with partners like Health Fairview is that there's no single one of these stages or technologies that's enough. You really need all three to drive and sustain change. And going a step further, I mentioned earlier we've got these out-of-the-box patient flow solutions that are tried and true and proven to work, and this is what they look like, right? So we play in a lot of areas of the acute care setting and the system settings, but the focus of our webinar today is going to be mainly around the box on the right, the inpatient, and the box at the bottom, which is the system. We show this to just illustrate that there's great work being done in other areas as well. So switching gears to essentially the meat of the presentation, why we're all here, let's talk a little bit about the digital transformation at Health Fairview. So Julie, thank you so much for taking the time today. We're really honored that you're actually sitting down with us. But I'm hoping you can set the stage a little bit and tell us a bit about Health Fairview and some of the goals that you guys have been working towards.
Yes, thank you, Ahmad. We are a 10-hospital academic system with about 60 outpatient and ambulatory clinics. We have over 2,100 adult and pediatric beds, and then also a few hundred mental health beds across our entire system. We just joined 2 health systems into one approximately 2 years ago. So along with everything else, we're still combining people, processes, and 2 instances of our medical record, which is EPIC. Our system covers the spectrum between suburban community hospitals all the way to urban safety net hospitals. The university specializes in complex patients such as solid organ and bone marrow transplants, cardiovascular, and some very extreme behavioral health cases. We also have the Masonic Pediatric Hospital, which performs solid organ transplants, bone marrow transplants, and has a large volume of oncology pediatric patients.
Great. So having such a complex system, what are some of the flow or operational issues that you guys have chosen to address, especially given that you guys are merging 2 systems into one?
Yes, well, like your charts that you showed, the length of stay is creeping ever so slightly upward, which has been the downstream effect of reducing patient care access to the help that they need. So reducing our length of stay is important, but it's also important to ensure that our patients stay within our system, and it's important to ensure that our staff and our physicians are brought into that mission. But as we're asking our staff to buy into our mission, we also have to work as leaders to help them do the work differently and to provide them the tools to do the work efficiently without creating additional burden on them. If we do all of the above well, it'll have the net effect of reducing complexity for our patients. Our patients will be able to trust that when they're going to any of our Health Fairview hospitals or clinics that they're getting the same high-value care, and it's easily, regardless of where they're at within our large system.
Yeah, absolutely. And, based off some of those goals that you guys are trying to improve upon, let's take it a step deeper. Can you talk to us a little bit about what you guys have tried in the past to address maybe length of stay or excess days, and what worked and what didn't work?
Yes. With combining 2 systems, needless to say, we had various PI initiatives happening, which have led to many different initiatives with no standard priority of what's most important. With those improvements in the past, it's generally been somewhat of an immediate need at that time, but we moved quickly to the next initiative, and the improvements we saw weren't always sustained. There are challenges with being so large, and these challenges have been amplified by our merger and growing quickly as a large system. One thing that came readily apparent was how many silos that we have accidentally created while trying to do the right thing, so we didn't have really a single approach. to solve our problem and reaching our goals that we all want together. In the past, we've actually had several different tools and dashboards. Some of these even had conflicting information, and with that, the trust in the data wasn't always there. It's almost at times I felt like we had too much information, which also causes overload. Many of our dashboards that we've worked with in the past weren't in real time. So when we were looking at the data, it was actually stale, so it was really hard for us to make good, informed decisions.
Yeah, absolutely. And you talked a bit about kind of doing the right thing there. So can you talk to us a little bit about, Fairview's approach to coming together as a system, coming together as, with a shared vocabulary, a shared understanding, especially for a system as large as yours, you guys decided to take a pretty novel approach. So can you talk to me a little bit about, what you guys are doing and why you guys have chosen this journey?
Yes, as a large system, it's become apparent that at first we didn't have a strategic plan to be able to take care of all of our patients in such a wide variety of settings. We knew we needed to have a focused and centralized approach so we could streamline the capacity to create for the high level in more of a coordinated manner. We were acting more like several independent hospitals versus a large system. We were putting the burden on our patients to navigate the complexity of our system instead of making it easy for them to come to mHealth and seek their care. At the same time, it became apparent that we had resources that at times were underutilized at our facilities, and then some resources at a sister facility were actually overutilized and were really struggling. I have a really great example that one of our hospitals was overburdened in the ICU and couldn't accept any more patients, and we were actually transferring them out of our system, which just 20 minutes up the freeway, we had another large hospital that actually had ICU beds with staff that could have accommodated those transfers out. So looking at this, it was very apparent we needed to do something. So the goal was created to centralize operations to create this center that we could serve as a source of truth for capacity across our whole system. So with this, we're looking at that our patients, families, providers, and our staff can call in and get access information across the system in one central location.
Yeah. And, you guys decided to take the system approach or the command center approach, but your approach even, command centers are novel enough, but even further, you guys decided to take a bottom-up approach where traditionally command centers come from a top-down approach. So can you talk to me a little bit about why you decided to go bottom-up and focus on the sites, and then why you decided to focus on inpatient more specifically to start with?
Yes, when we took a look at our system approach, we decided it would be best to start one hospital at a time. So we decided to, for this, focus on inpatient because we knew that if we don't unlock capacity there, we have downstream bottlenecks in our emergency room and our peri-op areas. When we look at throughput, we can't just look at getting patients out from the ED or admitted to the hospital. We have to look at how we're going about that to create the capacity for the inpatient units to be able to get the patients from ED and peri-op areas sooner. So as we looked at process across our hospitals, we realized we had a lot of variations in processes and how we plan for the discharges, how we do bed planning, etc. And it's really human nature that our individual nursing departments will come up with their own processes, and at times they don't even realize that they're creating more inefficiencies than creating deficiencies that when we realize that we need to get standard processes. So the goal is to speak the same language, look at the same data, and then be able to communicate across the whole system.
Yeah, and just two things there that stood out to me were everybody creates their own processes. We like to call it Quantus. The workarounds are working, and so they keep perpetuating. And then around the shared language, I couldn't underscore that enough. We see this all the time that even if we go into a system, there might be 2 or 3 different definitions of census or EDD or things like that. So how can you even affect change or capacity at a system if you don't start with the site? Yeah.
Yes, absolutely. We definitely have a lot of that, so we had to really tackle that quickly.
Yeah, fair enough. And yeah, so double clicking a bit into inpatient and length of stay. So can you talk to me a little bit about, what it was like managing length of stay in a pre-Qventus era, and how, what was the discharge management process? How are you guys actually measuring and guiding length of stay changes, et cetera, and just, the approach that you guys had previously?
Sure. A lot of moving parts to helping to get our patients discharged really timely. Most of our hospitals, I know here at Ridges, where I'm the chief nurse, that our providers have a patient list that they round off, but the effectiveness of the round itself is really highly dependent on each provider, and as all hospitals with our patients, they often have consultants involved in the patient's cases also. So we've experienced a variety of multidisciplinary rounds to try to work with this. Some which are effective, however, with the complexity of our patients' medical needs. And I have to say the increasing of social needs that we're seeing, that our care managers still spend a lot of hours arranging these discharges that are so complex, a lot of burden on them. In the past, we've also found that leadership doesn't really realize something that's going really wrong with that discharge until it's been very much delayed. And at that time, the patient's already had an extended stay and increased length of stay. So a lot of times in the past, issues weren't elevated quick enough, and then we didn't have the right resources, and the communication was a gap.
Yeah, no, absolutely. And honestly, it's kind of a great segue for the points that you highlighted, to just remind everybody of the approach that we'll be talking about, and or the context of the approach that we'll be talking about in the next few slides, that it is really about identifying issues in real time or proactively planning, but then also reducing the burden of the coordination by orchestrating actions and automating some of those actions. And then, of course, to your last point, just about managing the accountability in real time or daily, just to make sure that we're actually driving and sustaining our changes. So this will be the context in which we kind of talk through the next few slides. So here we see the Qventus Pathfinder board for MDRs. It's part of the identifying issues piece of our approach. So Julie, can you talk to us a little bit about Pathfinder, how it's leveraged in your MDRs, and how it's helped you and the organization kind of standardize things and manage a bit better the length of stay process? Yes,
the board has really become helpful for our charge nurses, our frontline staff, and definitely leadership. We now utilize this every shift. At first, we started just on day shift, which has really been exciting that we are now using at our charge nurses around the clock. Prior to implementing Pathfinder, we were inconsistent in documenting our EDD into Epic, which is led by the doctors. So we did have to do some work with them and communicate how important that is for this work. So it comes to the visualization that's really important to us, and our charge nurses have started relying on it as a handoff tool for them when they go shift to shift to the next charge nurse, to really ensure that we have consistency in communication, looking at those patients that are anticipated for discharges the next day and even 2 days out. So highlighting the barrier section helps our charge nurses and our care transition team to identify those barriers that they need to focus on for those patients during those shifts. It also allows our staff to work with families to explain what's remaining in the discharge process and how that they can also be able to help us, really allowing them to help own the care of their loved ones and working alongside us.
Yeah, and I think that's a great description. So that's kind of the first wave of the Pathfinder, getting that standardized language, getting the standardized approach. Can you talk to me a little bit more about the intelligence that you guys are looking to move forward with?
Yes, as we're getting more mature with our rounding process, we're looking to start the next step of intelligence. Our charge nurses are extremely excited to move into the next step and look at those SMART barriers to help them with their decision making. I think they feel like they've somewhat tackled our care progression huddles and utilizing Pathfinder. So they are excited about what's going to help them next. So they're excited to take the next step.
Yeah, and so the intelligence that Julie is talking about for folks on the phone are things like our predictions on when patients are going to discharge, 24, 48 hours out. And when they discharge, predicting where they're going to be dispositioned to, so where are they actually going. And then also predicting, what the capacity is going to be, 4 hours from now or 2 hours from now or 4 days from now. And really leveraging that, and getting that information to the frontline teams. The goal is to start some of these conversations much, much earlier so that you don't have those downstream, oh, I forgot X, Y, and Z type scenarios. But if you do, that's exactly where our smart barriers come in. So it is essentially looking at your EMR and saying, hey, there are EDDs within 2 days or or tomorrow, but somebody just ordered an MRI. There's no way this MRI is getting done. Please surface this smart barrier up in rounds and see if we can either get it prioritized or reschedule it to outpatient. Or, hey, this patient is going to subacute rehab or skilled nursing facility, but nobody's put in a PT order yet, and it's on day 3 of their length of stay. Somebody, surface up a smart barrier saying, hey, this patient needs a PT order right away in order to meet the discharge goal. So just kind of highlighting some of the intelligence Julie was talking about.
It's exciting.
Yeah. And so the second piece, and this is where we kind of get into the data that Quantus can provide, is identifying opportunities also to orchestrate action, right? So where do we want to go now that we've actually got the shared language? And so what you're seeing here is essentially some of the data that's being surfaced from Pathfinder directly to Julie and her management team to decide where to go next. Julie, can you talk to me a little bit about what we're seeing here?
Yes, definitely. As we're seeing in Quantus, the reports are breaking down all of our barriers to discharge, so we can look at those on a regular basis, the frequency of which they're occurring, and then the associated avoidable days, which is really important. We receive and review this data on a regular basis, as I stated, and then it helps us to inform what new orchestrations we may want to undertake. So as you can see on this chart, physical therapy and occupational therapy have come up a fair amount. So as we decided, I know our Southdale Hospital has looked at this also to start with our ancillary prioritization efforts focused on therapy. For example, this will speed up our PT or OT look at the schedule times set and then possibly move the times up to assist in discharging that patient earlier.
Yeah, and then it just kind of sets it up perfectly for going into the orchestration itself. So now that you guys have identified therapy as the area to start orchestrating, can you tell me about how this orchestration affects frontline staff or providers?
Our frontline inpatient nursing staff, they spend a lot of time of their day tracking down updates on patients' care, updates on the discharge planning, of course, and the other updates on barriers to discharge. So the goal here is to automate some of this work so our staff can get back to delivering really the high care, quality care that they want to provide our patients. So the orchestration works such as this. So the therapy manager sees a prioritized list of patients who are facing therapy as a barrier. So typically there's too many orders. So they're all showing up as stat, kind of once again human nature. But how do we know which one to prioritize? So it's first in, first out, and a lot of manual back and forth phone calls that take place with a lot of these. So with Quantus, there's machine learning that factors into that prioritization process. This makes it very clear which patients' therapy orders need to be prioritized to avoid that discharge delay for that patient. Now, care managers can cut down the manual back and forth phone calls needed that they were chasing those barriers around. We're hardwiring coordination pathways and saving the team's time with doing all this. We can also provide prioritized work lists or nudges to the teams on their mobile devices in real time to collaborate on the orders that come in as barriers.
Yeah, absolutely. So for folks on the phone here on the left side is an example of the work list or the prioritized work list that Julie was mentioning. And on the right side here, you have kind of an example of a Quantus nudge to a mobile device and the collaboration that takes place to resolve some of these barriers to discharge. All right, so that's an example of orchestrating action. So now we obviously want to close the loop and making sure that everything's getting done that we want to get done. So there's the manage accountability piece and the data that Quantus is providing. So what you're seeing here is essentially the discharges before 11 compliance per unit, and Fairview's got kind of a initiative that they put around this that we really wanted to kind of bring into that we kind of set up reporting around and empowered by the Pathfinder. So Julie, can you talk to us a little bit about the effort and how you guys have been using it?
Yes, Quantus has been awesome partners with receiving reports every morning. I receive these, and it really helps me to plan my day and look at where we're at. So we also implemented what we call our daily engagement system this past summer. We are now reviewing every morning to ensure that the changes we put in place are being sustained. So our goal is to identify in every unit 2 patients that we can discharge before 11. We even say 12. We want early discharges. So this has increased our leaders on the unit's accountability to focus on this among working with our charge nurses. And it's actually built excitement within the staff that they can see on our daily engagement system the actual numbers, so it's a real visualization to them. When I round throughout the hospital, I've often run into nurses, and they'll stop me and say, "Hey, we got 2 patients out by noon today," and they're so proud of themselves and happy that they understand what that goal is about now, and the metrics mean something to them. So this visualization has really helped a lot. It's definitely a journey to sustain and to keep that excitement going.
Yeah, and I think, Julie, what you said is also a good example for folks on the phone. Fairview had a really great management system that they were already implementing that they wanted us to plug into. So that's an example of where, we didn't have to do, too much change management around the management system, just provided the data. But, at other organizations, we can obviously come in and actually help set up these management systems and visual systems that Julie is actually referencing here. Okay, so now zooming out a bit, we've talked about the inpatient piece and the bottom-up approach, the 3 ways that we kind of approach all of our initiatives, and let's actually talk about the capstone of the project, which is kind of the System Operations Center. So Julie, can you talk me through a little bit about, the System Operations Center, where it is, and why we decided to kind of focus on these 3 areas on, a functionality?
Yes, Quantus and Health Fairview partnered to co-develop the command center for reasons that we talked about earlier in this presentation. The first thing we did was to co-locate our various bed placement teams, which we actually had 3 large teams serving the 10 hospitals, so we brought them together at one location in our what we call our SOC, System Operations Center. We then hired what we're calling a flow analyst, whose full-time job is to proactively monitor and manage the bottlenecks that occur throughout the system. The role is important for us because in our previous state, it was everyone's job to pay attention to operations and the potential capacity constraints, which many of our hospitals have those. Now that we have a full-time dedicated resource for this, we're hoping to unlock a lot more operational efficiencies as we mature our System Operations Center. We chose to focus on 3 themes for our first phase because we think that they provide some of the low-hanging fruit for lurching us forward. The first is the system-wide situational awareness and the hotspot anticipation. Quantus allows us to look at real time across our system and know exactly where hotspots are. But additionally, it's the machine learning that allows us to predict where those hot spots are. So that's the red that you might be seeing here on the screenshots. The second piece is site-level capacity management. We've set up all of our hospital sites and our SOC interactions such as that our hospital sites will know that when they call upon the SOC that they have help there if they need it. The third piece is proactive problem solving across the system. This is almost the inverse of the second, where our flow analysts might notice an upcoming issue that the site hasn't even had a chance to figure out yet, and alerts the site, usually it's our house supervisors, not only the upcoming issue, but puts into motion agreed upon standard work to avoid high capacity situations, for example. our system has placed a great deal amount of work on our standard processes throughout, which is no small task as large as we are with the 10 different hospitals. The other thing I like to add is the terminology. That was really somewhat difficult, but yet it's a learning process that we are gaining relationships and being able to know what our terminology means so that we're all standard across the system. And once again, that's been a journey.
Oh yeah, that was a lot of conversations about definitions and vocabulary. Yeah. All right, so let's double click a little bit. Some representative workflows. That's what we're kind of showing here within the 3 buckets. Obviously, it's not exhaustive of the types of things we're tackling in the command center, but just kind of 3 representative workflows. So Julie, could you talk us through what we're seeing here and what we're focusing on?
Yes, so the first one is our system patient flow huddle. We put this into place to have at least 2 dedicated touchdown times throughout the day where cross-functional and cross-hospital staff can huddle with our flow analysts to review the key flow metrics that we've identified and try to problem solve. So we've identified and continue to iterate through standard work associated with any barriers to flow, as we call them up. We're having standard work and accountability with the flow analysts that the work is being followed is a key component for this touchdown when we meet. Many times in the huddles, items are brought up, and yes, someone might say, I'm going to get X or Y done, but how often does accountability stop there? So we need to continue to review that, and then at the next huddle to make sure that we've accomplished that. So it's kind of like having a service level agreement that I'll have that done in an hour. So we can actually measure if there's any barriers and what we were able to resolve. So the second workflow is keeping us honest as we've identified in Pathfinder during rounds. We identify the possible discharges, the definite discharges, and discharges before noon. Quantus automatically checks for whether the patients who were designated into each of these pieces, these different 3, are actually discharged on time. Additionally, the machine learning looks at predicted census to identify how many of each we might need or when beds need to be opened up to meet the incoming demand. The last workflow was a bit further out, but realizing the need to perhaps bring it forward in our journey, and that's to identify hours ahead of time in an ED with a patient who needs to be admitted that cannot be accommodated at a current hospital. I mentioned earlier in the session that we were having patients leave our system because our ICUs were at capacity at one of our hospitals but could have been admitted to another easily. So with Quantus machine learning, it identifies likely admits ahead of the time and automatically checks the capacity at the current hospital to ensure that they can be accommodated. If the patient can't be treated at that hospital, then Quantus helps us to check the capacity at one of our other nearby hospitals to look, and then also, of course, to work with frontline health supervisors and the flow analysts to follow that through. So this is one of our more powerful workflows that we're hoping will make a big dent in transferring patients out of our system and our diverts.
Yeah, absolutely. Thank you so much for that overview on that. And so now I want to kind of switch gears, now that we've kind of talked about both solution sets and the journey that we're on together, to impact. So what we've got here is essentially the impact of at Julie's hospital. And, the way we like to do this is essentially we have a data science team that looks at, pre-intervention and post-intervention, essentially before Quantus and after Quantus, impacts on length of stay. And we both have adjusted and unadjusted length of stays, accounting for a bunch of statistical controls. So, Julie, can you walk us through some of the, this impact that we're seeing here and, what you guys did and, how you guys got to this point?
Yes, it has been our journey. As when we went up on Pathfinder, the first thing that was very important was the communication of the why. Why are we looking at this, and what is the impact that's going to benefit us and our patients? So provider communication was key. We have had a fairly good length of stay here at the Regis hospitals, but we're always looking for opportunities. So providing communication to the physicians and listening to what they had to say also. We did decide to start with one unit first to kind of work out the kinks, and then we added the rest of the units. And it was really fun. We felt the unit we piloted was kind of going to be our go-getter and start off fast and furious, and there was a learning process there. As we added the other units, we had one that we really didn't suspect would move and adopt so easily. They took right off and have done really well with Pathfinder. So it really was working with all the teams, the staff nurses, the charge nurses, and then our care management team has been very important with this. We touch base weekly. The unit managers come together to discuss what's working well with flow, anything that we can think of that we need to do differently. We've actually also worked with one of the other hospitals that went up prior to us and have learned from them. So that's really been a beneficial to us, that there's been some learnings. One of the things I can't stress enough is the relationships built with this, that we have to make sure that our leaders feel involved, they have a voice, and our providers, and it's really building those relationships, and we have a good culture here, so that is a real positive to start with, but it takes everyone. And it also takes that relationship with our patients and their families, because when we look at discharge, we need them on board at the very beginning also. So it's a journey. We continue tweaking. It's change management. You really have to monitor each unit. How are they doing? How are your leaders doing? And that's one thing I'll talk about here in a minute is that's a key point, is making sure you have some leaders that are really inspired to help with this new technology and understanding what it means. And Quantus has been very helpful with us.
Thank you. Yeah, absolutely. And, kind of switching gears to another impact. I mean, one was like the stay, reducing midnights. This was another one, which is creating capacity earlier in the day. Obviously, we've seen some sustained results here. Can you kind of talk us through Regis's approach and, how impactful it's been?
Yes, the AIM discharges are very important. As we know, our EDs start getting very busy early to mid-afternoon. So we task our units to really try to focus in and identify at least 2 patients that they felt could be discharged before 11. Not only are we able to monitor our discharges before 11 in real time with Quantus, the results here also have tied heavily into our daily engagement system that I mentioned earlier. We're really honed in on getting discharges dates, the EDD, and as accurate as possible by the physicians. It also takes real collaboration between the staff nurses, the charge nurses, and the providers to think about things that we can do around the clock. I think in the past we focused more on what can be done on the day shift to get our patients discharged, but it really takes every shift. What has also been exciting is to see how many discharges that we're seeing earlier in the day before that mid-afternoon period that we saw in the past, and it's amazing to see the impact that it's not quite as hectic in the afternoon as what it used to be, that even those few discharges that can happen on each shift in the morning can really make a difference in your afternoons.
Yeah, no, absolutely. We're really proud of both of the hospitals and how well they've been kind of adopted this, and it's almost a struggle a lot to convince people to get the discharge orders in earlier, but both hospitals kind of taken to it. All right, so kind of parting thoughts, Julie, for everybody on the phone. Obviously, you've been through this journey. You've been, living it and breathing it for the past couple of years. What sage wisdom could you impart on folks who are thinking of doing something similar and undertaking some of these pretty massive projects?
Yes, champion identification and engagement is so important. One of the things I can't stress enough is choosing a key director or directors and managers that really are inspired by change and like innovation. Communication between our providers and our frontline staff, and making sure that the executive team was on board and understand what our goals are. So conducting champion working sessions, having our staff involved was also very key. So you have to be patient. That's one of the things in healthcare. We're always very used to change and always focusing on trying to provide better care, but you have to watch your team and make sure that they're adopting and moving with you and to listen to them, which I think was really beneficial here, that they had a voice, they were heard, and said, let's try this, so we would try things. And it really turned out to be a positive, and we're meeting our goals. It's really an achievable outcome, and it's been a lot of fun along the way.
Well, it's been a lot of fun for us too. Although at times, we had to work through some struggles, but it's been so much fun, and obviously Fairview is just a phenomenal partner regardless. So, all right, let's switch to the Q&A. So I'll hand it back over to the Becker's crew.
Yeah, thank you so much, Ahmad and Julie, for that fantastic presentation. We will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we have time for today. We've already had several questions come in throughout the presentation, so I'll go ahead and get started with those. The first question, I believe, is directed for Julie, and the question is, how did you go about engaging providers to take part in predicting or setting an estimated discharge date?
I worked with our lead hospitalist, which is actually our VPMA, Vice President of Medical Affairs here also, and talked with him about some of the work that the hospitalist team had already worked on related to our length of stay. So having that communication was so important, as well as meeting with and working closely with our care management team, how important it is to identify those patients and to put that EDD into Epic, and so we can use Pathfinder to help us put in the barriers and be monitoring from the very beginning.
Thank you so much, Julie. Moving on to the next question. This one has to do with adopting change in new processes. So Julie, I believe this one's for you as well. So the question is, it's often challenging for teams to change their behavior and adopt new processes. How did you overcome this?
I had a couple different ways I looked at this. I really knew I have some very strong leaders here that they're very inspirational and they really like innovation. So I keyed on them where they were at in their leadership journey and helped them to lead this work. The younger leaders, they're driven by technology. So having them on board as well as their excitement helps to inspire the staff. So with the machine learning, that's where that excitement and journey is at now, and they're really excited to continue moving, but it really is to get the right champions on the work from the beginning and just ongoing communication and share when things haven't gone so well, because we did have some hiccups, but we just kept at it, and we knew we could see some results in the long run.
Great advice, Julie. Thank you so much. The next question that came through I believe is directed to Ahmad, and the question is, what recommendations do you have for folks who are using Epic, and why did you need another technology on top of your EMR? So Julie or Ahmad, I think you could maybe both have perspectives to share, but whoever would like to answer that question, please chime in.
Yeah, Julie, do you want to get us started, and then I can add color?
Yeah, sure. The data isn't within Epic. There's a lot there, but we needed a partner to help us to deal with that data and how is that meaningful to us. And that's where Quantus has been able to help us with our reports and really to have those visual tools.
Yeah. And I completely agree with that. Epic is there. It's built for clinical data capture, but, not necessarily built out in the way that needs to be for operations, right? So the data in Epic is extraordinarily important. We partner and integrate with it deeply, but it's the automation of the operations that we bring, the AI and the statistical processing of the analytics that we bring, and then also it's also about embedding behavioral science into our solution, right? So it's not just about surfacing another dashboard or surfacing another piece of information. It's more on, of the 10 pieces of information that are out there, what are the 2 or 3 ones that have the highest impact? And then who are the 2 or 3 people that we can get them to actually, realize that impact? And that's really the name of the game. And so we've had a lot of experience helping hospitals and Epic transform operations as well. So, it's not like it's something we shy away from. I'd say maybe over about 75–80% of our hospital partners are actually on Epic. And so, it's kind of our bread and butter. We really don't shy away from it. We really like to partner with the organization.
Thank you both so much. We've had several more questions come through, so we're going to continue to try to work through a few more before the top of the hour. The next question for you, Julie, is, does your flow analyst manage on the entire system for the systems operations center, or is there a boots on the ground flow analyst at each site who can interact with the units, physicians, and charge nurses?
The flow analyst is located at our system operations center. So currently there are 2 people in those roles. So they actually work very closely with our house supervisors at each hospital, which of course are ongoing working with the charge nurses throughout every shift, every hour, I should say. So it is via texting, it's via some phone calls.
Yeah, and I can add some context there as well. The key is that the flow analyst is centralized, but the goal is creating processes and procedures and standard work around anything that's identified by either the flow analyst or the system itself. So even though that they are centrally located, we don't necessarily operationalize a workflow until we have done the due diligence and training and working with our site leaders and frontline teams or providers to kind of operationalize and work closely with the flow analyst. So it's one of those, everybody should know what the conversation is, and everybody should know what everybody's role is, and no initiative should really be rolled out beyond that or without that.
Great, and we have one more question that's kind of a follow-up to that one, and this person is just wanting to know if you can describe the role or the credentials of the flow analyst.
Emma, I'll let you take that one.
Sure, yeah. So the flow analyst, we actually looked for folks who were already at Health Fairview. We honestly looked to some degree for clinical prowess, but for a lot of it more on the operational prowess and what they understood about the operations of the system or the sites and the individual workflows. So I think the 2 folks in the roles right now, one was part of patient placement beforehand and is now into the flow analyst role, and the other one, God, I forgot, he was one of our transfer specialists. So he was the one kind of answering the phones and coordinating where patients need to be going within the system when somebody called the Fairview number. So that's generally the background that we've looked for, is how familiar are you with the placement process and the operational process, and then how inquisitive are you for uncovering bottlenecks or kind of following up on hotspots or diving deeper into the real-time information that we're giving.
Great, thank you for providing the clarification around that role. And the final question, it looks like we have time for about one more question today, is this person is wanting to know what other roles or people sit in the Systems Operations Center.
Yeah, I can take this one too. So we've got the flow analyst. I think Julie mentioned that we centralized the patient placement organization as well. And that's kind of the start. Those are the kind of the core teams that we thought about, that, hey, these are the ones that need to be together to at least impact flow. And I think as we're maturing, we're recognizing, okay, we probably need somebody from transportation in there. We probably need some folks from staffing and scheduling as well. And so we're kind of working in that in that direction. And Julie, do you want to add anything around that? I know there's been a lot more maturity around the staffing and scheduling stuff.
Yes, we did last summer also move all of our staffing and scheduling departments to the central location. And the hope as we mature is that there is closer communication, because needless to say, you have to have staffing to be able to have patients admitted to your hospital. So balancing that out and having that coordination between staffing, patient placement, and our flow analysts, that there's a connection between all of that.
Great. Thank you both so much. That is all the time for questions that we have today, but Ahmad or Julie, do you have any final thoughts you would like to share with everyone today before we wrap things up?
I think my last thought
sorry, go ahead.
Is to really have your key leaders involved and to have that change management process incorporated in it also. And it really is having that accountability and having the providers and the staff understand the why behind this. And that we all know when our patients come into our emergency room, they want to stay within that emergency room if that's where the care is. And so we really have to continuously be working on bed capacity and how important that is. So you really have to continue to communicate broadly and ongoing.
Yeah, and the only thing I would add is that it's achievable. All of this sounds daunting. I know these are all problems we've all been working on for a long time, but it's absolutely doable. And, just don't be shy to actually approach the problems.
Well, thank you both so much. That is all the time that we have for today, but I want to once again thank Ahmad and Julie for their excellent presentation and Quantus for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.